Hello, and welcome to our WM community members from around the world. I am Michelle Postek, IWMF Manager of Information and Support, and I want to thank you for taking time out of your day to learn about the hot topic of peripheral neuropathy. I want to thank IWMF PN Planning Committee members, Bob Ulkus, Eileen Sullivan, Jane Loud, Joel Rosenblit, Lisa Wise, and Steve Pine. All of the folks I just mentioned are IWMF volunteer support group leaders across the United States, and I am grateful for their partnership in planning today's program. As I mentioned earlier, Joel Rosenblit is also one of our Lifeline peer mentor volunteers for the topic of neuropathy. And in fact, our Lifeline directory has a plethora of volunteers for topics related to WM. Be sure to check it out. It is my privilege today to not only introduce one, but two rock star physicians from the Mayo Clinic. We will have both presentations, and then with remaining time reserved for Q&A, which will be co-moderated by me, Eileen, and Steve. I will now introduce our speakers, and then we will move to their presentations. Dr. Michelle Mauermann studies disorders that damage the peripheral nerve system through neoplastic, inflammatory, or genetic mechanisms. She uses human clinical trials in her research. The long-term goals of Dr. Mauermann's research are to elucidate the mechanisms of neuropathies and plasma cell disorders and to improve treatment of hereditary amyloidosis, plasma cell disorders, and inflammatory neuropathies. Dr. Narayan Kissoon is also here with us today, and he studies the mechanisms of action and clinical outcomes in treatments for headache and chronic pain. This research includes clinical trials investigating the efficacy of minimally invasive percutaneous interventions and the impact of pain treatments on nervous system function. Dr. Kissoon also investigates the abnormal function and structural causes of pain disorders. As part of his research, he reviews the clinical features that predict successful treatment outcomes. I will now turn the program over to the doctors for their presentations.
All right, I'm just gonna share the screen here. Hopefully you guys will all be able to see the slides. Does that look good to everybody?
Yep.
Okay. All right. Well, thank you very much for having me today. And I'm excited to talk with you about peripheral neuropathy. So this is just a pretty picture of what your nerve would look like under the microscope in the background here. So this is if we took a sample of the sural nerve, which is the one, if we ever are going to do a nerve biopsy, that's kind of the most common here. And this just gives a little bit of a picture of the structure of the nerves. You can see there's lots of different nerve fascicles here, these circles. These are all nerve fibers, these little donuts here in the nerve. And we can see lots of blood vessels and connective tissue around the nerve. And these are kind of some of the different features that we're going to look at when we look at a biopsy. That's what's there underneath the skin. All right, so in terms of what are we talking about when we talk about peripheral neuropathy? Usually we're talking about damage to these peripheral nerves. So you can see each peripheral nerve has a cell body, and then it has an axon. And then there's the myelin sheath that coats around the nerve that helps the electrical impulse spread down the nerve. So we also tend to talk about different fibers that make up the nerve. So there's not just one population of nerve fibers in there. We talk about the large myelinated axons. Sorry, my mouse is going. There we go. That control motor function and sensation in terms of where our limbs are in space and how we feel touch. The smaller myelinated fibers that do pain and temperature, and then the unmyelinated fibers that are in the background here that do more pain and autonomic function. So when you're evaluated for a peripheral neuropathy, this is kind of what information we're trying to gather to try to put the peripheral neuropathy into different categories for further testing and diagnostic evaluation. So kind of thinking about all those questions. So let's go through each of these. So first, we're trying to determine which nerve fibers are involved. And so we're going to kind of break these down into sensation, motor strength, and autonomic. So sensation, we're going to be thinking about, do patients have positive sensory symptoms? So those are the sensations that are there that shouldn't be, like a positive prickly, tingling, sharp electrical shock, sensitivity, burning, freezing. Those are all positive sensory symptoms. Then there's also those that are kind of an absence of sensation, more described as like a dead type numbness or a coating sensation. Something like wrapped, like bubble wrap around the foot, we hear, feeling like you have socks on, but you don't. And then just the gait imbalance that comes because of the lack of feeling. So motor, because most neuropathies are length dependent, and that meaning they involve the longest nerves, so they affect the feet first. Motor weakness that we're concerned about is difficulty lifting up the toes or the feet, causing the feet to slap when you walk, or decreased dexterity of the fingers, so trouble doing zippers, opening bottles. And then we'll also want to assess proximal strength, so things like getting up from a chair or lifting objects above the head. Autonomic are those functions of the body that you can't control, that just happen automatically and are controlled by the autonomic nervous system. So things like lightheadedness upon standing, dry eyes or dry mouth, postprandial bloating, so feeling nauseous or bloating after you eat, vomiting undigested food, constipation, diarrhea, urinary complaints. There's a variety of those, abnormal or absent sweating, and then erectile dysfunction in men. Then we're going to try to figure out where the neuropathy is affecting. So again, we want to know mainly, is it equal on both sides, symmetric, or is it asymmetric? And is it length dependent or not? So is it really, like in this picture, evolving the longest nerve first, and as it gets more severe, spreading up the legs, and then as it gets to the knees, going to the fingertips and spreading upwards? That's a length dependent pattern. Or is it an asymmetric, more patchy, where you can see there's abnormalities involving multi kind of focal areas around the body in the picture on the bottom? Then it's important to us to know how the neuropathy evolved. So for me, I'm most concerned of, does someone remember really like when the neuropathy started? Like Tuesday, when I woke up, I had blank. Versus those that have kind of just snuck up on you and it's hard to remember exactly when it started, and it's kind of slowly evolving over time. And that helps me discriminate from different types of causes as well. So we're going to talk about, how did it come on, and then how is it evolving over time? Is it kind of going in a stepwise pattern? Is it getting better, getting worse? Is it just slowly or rapidly worsening? Then why? So we're really, especially in patients with Waldenström's or other plasma cell disorders, we're really going to want to get more information about the underlying disease or other possible associations. So in particular about the Waldenström's diagnosis, what's going to be important is, have you had any treatment yet? What kind of treatments have you had? And so in terms of other treatments that are associated with Waldenström's that on their own can cause neuropathy, some of the chemotherapy agents. We're curious as to whether or not you've had cryoglobulins as a component of the Waldenström's. Have you experienced problems with hyperviscosity? And have you been diagnosed with any associated amyloid deposition as a part of the Waldenström's? As all of those can be associated with neuropathy on their own and have a little bit different characteristics or phenotype of the neuropathy. And then, of course, we're always looking for, what are the other common causes of neuropathy? We want to know, is it really associated with the Waldenström's disease, or could there be something else? So diabetes being the most common cause of neuropathy. So of course, we're going to be asking about that. We're going to be looking if there's severe chronic kidney disease or HIV or other infections. Other autoimmune rheumatologic diseases, that could be important. If there's a concern for vitamin absorption, an issue with prior surgery to the stomach that may interfere with that. We're going to be looking for other systemic symptoms that could clue us into autoimmune disease or cryoglobulins or maybe amyloid that is evolving and hasn't been diagnosed yet. One thing that's really under-recognized is the genetic component of peripheral neuropathies, and it accounts for a large proportion of peripheral neuropathies that we see that are kind of insidious, kind of gradually coming on and slowly progressing. And so we're really going to try to do a detailed family history as to whether or not siblings, parents, grandparents have had similar symptoms in their feet, had difficulty walking, had to wear braces on their feet, slap their feet when they walk, have high arches, have hammer toes, all the things that might raise the suspicion that something could be genetic. And then clearly we'll also want to do the medication review. So any chemotherapy or immunotherapy drugs that have been received being the most important here. So when you get an exam for a peripheral neuropathy, we talked about the symptoms. Now we're going to do the exam that kind of goes along to try to, again, let us know what modalities are involved here. So we want to test sensation, and we often test all or some component of these different sensory modalities, like touch with cotton. We may do touch with the monofilament off in the office. We may use a tuning fork for vibration, a pin for the pinprick, temperature. We have a variety of different ways of testing temperature. We'll do a full manual muscle exam so we can see if there's any evidence of weakness, really especially focusing on those distal muscles in the hands and feet. We're going to look at reflexes. Reflexes are one of those core things that help us decide if sensory and motor weakness are coming from the peripheral nerves or could be a problem from the central nervous system, like the spinal cord. And then we want to look at the walking, and we're looking for some of the imbalance related to sensation or a problem with walking due to strength to weakness. And then we want to put it together. So we're going to look at the pattern and the fiber types, and we're going to describe that. Is it length dependent? Is it symmetric? Is it sensory, motor, autonomic? And so the most common peripheral neuropathy is a chronic length dependent sensory more than motor neuropathy. In terms of testing, what is some of the typical testing? Most patients or all patients with a length dependent peripheral neuropathy should have a diabetes evaluation, thyroid, and a B12, and a monoclonal protein. And patients with Waldenström's have had their monoclonal proteins looked at, but that's important to us in every neuropathy. And then in this setting, we may also do things like MAG antibodies. Every patient or most patients usually get an EMG to evaluate their neuropathy. And why is it helps us confirm that it's actually a peripheral nerve problem. There's patients who have spinal stenosis or low back problems and their symptoms mimic peripheral neuropathy. And so we're trying to sometimes sort that out. It'll tell us about sensory and motor. It'll confirm our pattern, and it'll give us some information we can't get from the history, like is it involving the nerve fiber or the myelin coating? There may be specialized testing that is needed in certain types of neuropathy, meaning like if there's a lot of autonomic, or if it's really atypical distribution, like it's multifocal or proximal distal, it's pure motor or pure sensory. If it's really acute or subacute, progressing really rapidly over weeks. And if there's systemic symptoms that suggest multi-organ or systemic disease, or there's a prior history or risk of malignancy, then we may go on to some of these other tests. And just to show you what those are, one test is the autonomic test. This is a test that has several different components to it, but it tests things like sweating and blood pressure and heart rate control. Sometimes the testing could include a lumbar puncture, which may tell us if there's a sign of an inflammatory disorder, if there's cancer cells. We may actually image the nerves in cases where we're worried about inflammation or maybe amyloid in the nerves or other lymphoma in the nerves in this case. A skin biopsy is a pinch biopsy that looks at the small nerve fibers in the skin and is used for small fiber neuropathy and can be used to assess for amyloid. Or like that very first picture, we may actually take a piece of the nerve and look at it under the microscope. And we're doing that not to confirm neuropathy, but really to understand why in select cases when we're concerned that it's an immune condition, vasculitis, like with cryoglobulins, amyloid, lymphoma, and the nerve. Those are the times where we might do a nerve biopsy. Just a quick couple words about peripheral neuropathy and Waldenström's. The incidence is about 40%. And there are many types of neuropathy that are reported with Waldenström's. The most common is a length-dependent sensory predominant neuropathy with imbalance that's been called DADS. Patients can also have neuropathies that involve those proximal and distal muscles. A polyradiculoneuropathy is what we're calling that because that involves the roots as well as the peripheral nerves. There can be painful acute motor and sensory neuropathies that involve like individual nerves. Typically, we see that in vasculitis with cryoglobulins. There can be a progressive sensory followed by motor neuropathy that can have pain and autonomic as prominent features. That's with amyloid. You can have a neuropathy or an individual nerve problem or a more diffuse problem in patients with other systemic symptoms. And they may have like cranial nerve involvement or facial involvement and lymphoma. And then there could be a painful distal sensory neuropathy. That's more common with the chemotherapy agents that I mentioned here. So just some general comments about neuropathy is that any small injury to the skin can cause serious infection or sores, and you want to report any injuries to your feet to your healthcare provider right away. You do not want to put a lot of chemicals or cut or file things on your own. You always want to wear shoes and sturdy slippers at all times. And you don't want to apply direct heat to your feet and legs because you may not be able to feel that and give yourself a burn. It's really important to look at your feet daily. Look for those injuries, look for any signs of infection or any change in the shape of the feet, and really moisturize the skin daily to try to prevent those cracks and places for infection to get in. It's important to care for the nails. Don't go barefoot. Again, wear shoes or outside at all times. Have good, really carefully choose your footwear. That's not something you're going to walk out of or trip or stumble on. You might want to keep the bed sheets off your feet if you're really sensitive to the touch. You want to make sure you're working with PT and having balance and safety evaluations if you have imbalance. You have a fall prevention plan, and that you continue to exercise because that's still really good for your nerves and your general health. So I'm going to stop there so Dr. Kissoon can talk about some of the more detailed management strategies besides just care, and then we'll have time for questions. So let me exit out of this, and then he can share.
All right. Well, thank you all for the opportunity to speak. Can you all see my slides here?
Yes, we can, Dr. Kissoon.
All right, great. So we're going to talk a little bit about how to best manage neuropathic pain associated with peripheral neuropathies, and going all the way from medications and also discussing non-medication strategies and even implantable devices. Some disclosures. I am a part of a scientific advisory board for a company called Bright Minds Biosciences. I have an investigator-initiated study with Nevro Corporation. Actually is a little bit of a related topic with diabetic peripheral neuropathy. Sorry about that typo. And then I get royalties from Up to Date. We will be talking about most medications used for neuropathic pain are considered off-label, but there will also be off-label discussion of CGRP monoclonal antibodies and neuromodulation. And then these are my credentials. Feel free to reach out to me if you have any questions. So with this talk, we'll review dosing regimens of first-line agents to treat neuropathic pain. We'll discuss medication options to treat neuropathic pain when these first-line agents fail, and then we'll also explore non-oral medication strategies to treat neuropathic pain. This is a nice little summary of medications that I generally go to first for treatment of neuropathic pain, and I use the characteristics of the pain and comorbidities to determine which medication to use. Gabapentin, a big thing to note is just the dosing of that, and I get people on as high as 900, 1200 milligrams 4 times daily. Pregabalin, a nice little trick that you'll get from this talk potentially is sometimes we'll do a switch from gabapentin to pregabalin, and you can do a 6-to-1 conversion ratio where if you're taking a dose of gabapentin and you're wanting to switch to pregabalin, sometimes you can stop the gabapentin and then switch at divide the dose by 6 for the gabapentin and then start the pregabalin at that dose when you're due for the next gabapentin, which is kind of nice. So you don't have to go titrate up or down on the medications. Another very common medication are tricyclic antidepressant medications. I find those very helpful with burning pain. Amitriptyline and nortriptyline are the most common. If weight gain's an issue, protriptyline is a nice alternative, which is weight neutral. And then I generally recommend getting an ECG if starting the medication over the age of 50 with a known history of heart disease or SSRI use. And then carbamazepine and oxcarbazepine are great medications, but hyponatremia can be an issue that needs to be watched closely. Lamotrigine, thinking about Stevens-Johnson syndrome, and lacosamide is a good I would say pretty 6th line agent where but you need to get an ECG before and after using it. So this is not all the medications you can use, but these are the ones that I kind of go to. With the amitriptyline and nortriptyline, talk about taking that 2 hours before bed. I always counsel people on dry mouth, constipation, weight gain, and sleepiness with the medication. And then we get in the EKG if there are any things that suggest that there could be a heart rhythm issue, and if they're on another SSRI type of medication. Generally, I will avoid this use with a medication like Wellbutrin or bupropion, due to drug interactions. And then there's always a risk of lowering the seizure threshold. But with some SSRIs, it may be okay, like duloxetine and sertraline, but you just have to be careful on the doses. And then we just gradually build the medication up over the course of 5 weeks, starting at 10 milligrams and going to 50 milligrams. Gabapentin's an alpha-2 delta ligand, and it modulates calcium through the voltage-gated calcium channels. It looks like gabapentin, but interestingly, it does not actually bind to the GABA receptor, which is a common misunderstanding. Its side effects typically are weight gain, sleepiness, and leg swelling. There are some extended release formulations that I will occasionally use if the immediate release aren't tolerated, but it was effective. And then that 6-to-1 conversion to Lyrica is always a good little trick. And I usually start it at night, and I start with 300 milligram tablets, and then I just add a tablet each week until we get to the highest tolerated dose, or 600 milligrams 3 times a day. Carbamazepine is a nice medication that's a sodium channel blocker. I think it's generally good for like electric type medications. And sometimes you can use extended release formulations to get more stable drug levels. Some things to think about are the rash that can happen, dizziness, ataxia, or troubles with coordination, blurry vision, ringing in the ears, are some things that can happen with that medication. The big things are hyponatremia and agranulocytosis and anemia are things that can be things to watch for with the labs, which I'll usually get a CBC, a sodium, creatinine, and then liver studies starting out about every 3 months when I'm using the medication. And then I'll tend to dose it 3 times a day and slowly build it up in the system. And the max dose is 1200 milligrams per day. And I'll even do like a 3 times dosing, and people find that it's a little more tolerated. And then the big thing with that is in patients of Asian descent, you have to be careful about this medication because they can have this HLA-B 1502 carrier haplotype that could put a risk of having a rash that can be life-threatening. Lamotrigine is another medication, and similar story. It's a sodium channel blocker. This one is got a well association with Stevens-Johnson syndrome, but if you do a very slow titration, that's not a non-issue. Big things are also to think about drug interactions, such as with valproic acid, ginseng supplements. It can be increased and then it can be lowered with like other medications like the carbamazepine, phenytoin, oral contraceptives, all things to keep in mind when you're using this medication. But if you go low and slow and are aware of the medication interactions, it can be an effective medication for nerve-related pain. And the last one I think about is lacosamide. It's also sodium channel blocker, and important to get an ECG before and after due to the issues with PR prolongation. We kind of build it up in your system over 3 weeks up to a dose starting typically 100 milligrams twice daily. But you can go higher. But that's that's down the road. Usually try the other medications first. So we've talked about the medications. We're going to talk a little bit about non-medication strategies for treatment neuropathic pain, topical creams being in that, spinal cord stimulation, scrambler therapy, DRG stimulation, and CGRP monoclonal antibodies that we typically use for migraine. The topical treatments, often you can do an over-the-counter lidocaine patch. That's a good go-to thing. The over-the-counter is 4%, prescription strength is 5%. Generally, the patches will be worn 12 hours on and then it's off for 12 hours and you put it over the most painful area. It can be a little tough if they're a large area of pain, then you're kind of all swatted up with patches everywhere. So it's more good for focal specific areas of pain. Otherwise, if there's a lot of musculoskeletal pain, we'll use Voltaren gel, which is a 1% gel, diclofenac, that's over the counter. For prescription compounded creams, we have a compounding pharmacy with them here at the Mayo Clinic. That can be a little hard to find a compounding pharmacy to find these, but we usually use a lidocaine 5%, ketamine 5%, amitriptyline 2% formulation. And I usually tell patients about 1 gram for a quarter size amount, and I show a little quarter size and you can apply it 2 times a day as needed. Kind of a nice little thing to think about when ordering these compounded creams is there's generally two formulations. There's like a Lipoderm PLO gel or a Vana cream. PLO gel is a little better for more focal areas, but the Vana cream is better for a little more diffuse areas. Worst case scenario with the Vana cream, you'll get nice, soft, smooth skin on the feet and help prevent ulcers and things in the feet. So in length-dependent peripheral neuropathies, the Vana cream kind of base is a way to go probably. So here's a case of a patient that I've followed, a 90-year-old gentleman with bilateral lower extremity neuropathic pain, nerve-related pain. Started about 10 years ago. This is related to type 2 diabetes. His hemoglobin A1C was 7.3%. And then about 3 years ago, he developed sharp pain with prominent allodynia. So allodynia is when light touch becomes painful. So non-painful input on the feet is painful. And then his exam showed some length-dependent changes that Dr. Mauermann described nicely. And the EMG showed sensory motor length-dependent peripheral neuropathy. His baseline pain was 3 to 4 out of 10, but with walking, whenever he'd walk, it'd be a 7 out of 10, maybe even higher. And we were having troubles with medications because he wasn't tolerating the gabapentin, even at low doses like 300 milligrams or 200 milligrams, and he had a little bit of dizziness. He didn't have any upper extremity symptoms, so we ended up going with a spinal cord stimulator, and this has actually recently been FDA approved specifically for painful diabetic neuropathy. The labeling for it is actually just a blanket of intractable neuropathic pain of the trunk and or limbs. But it was nice that this study here, there was a randomized controlled trial that compared its use with at least this high frequency system to conventional medical management. And they had overall better quality of life based on this scale called the EQ5D. The proportion of people with over 50% pain relief was pretty significant in the people that had the stimulators. whereas essentially nobody with just the medication treatments had any major pain relief. And their pain scores went from an 8 out of 10 to less than 2 out of 10 with treatment. So with our gentleman, even up to 12 months following, he was essentially pain-free with very rare episodes of pain. He didn't have that cutaneous allodynia, and his gabapentin was cut down from that 300 in the morning at night, 200 in the morning to 300 milligrams per day. And I think even more recently that was completely taken off because he was doing so well. And you can kind of see how we typically place the leads. We have a little battery that gets charged anywhere from once a day to once a week. And then there's leads that are anatomically placed. The goal target area is the T910 level, and they're staggered for redundancy so that we're able to capture the right spot and do reprogramming in case we lose efficacy over time. So the next treatment option that we sometimes think about is scrambler therapy. It's this treatment where it's given 30 minutes a day for 10 days. There are these, like, it's kind of like a TENS unit, but it's a little more glorified. It's got electrodes placed proximally and adjacent to areas of pain. The area it's most studied in is chemotherapy-induced peripheral neuropathy. And there's been comparative efficacy or studies comparing its use to just a traditional TENS unit, and it looks to be preferred by patients. And the majority of patients would recommend to others. However, with the small study that looked at it, there was no major differences at 8-week follow-up, so it should all be taken in that perspective. This was kind of their global impression of change and benefit at 2 weeks comparatively to TENS unit. And it looks like up until like 6 weeks, things were better, and then that kind of diminished over time after that. Most people were preferred the treatment and would recommend to others to use it even at the end of 10 weeks. Another option is DRG stimulation. So similar to the spinal cord stimulator, you stimulate the nerves and it kind of blocks that pain signal. Well, instead of the spinal cord being the target, the DRG is the target in this. The FDA approved indication for the DRG stimulation is this condition called complex regional pain syndrome, which is usually pain to a limb, and typically in this case in the legs where they had an injury, and then it had sensitivity to touch, redness, swelling, weakness in that leg. Dystonia is another thing that happens in that. So that's where the best data is for that. But in there's also these stimulators are used in other things like painful peripheral neuropathies, link-dependent peripheral neuropathies, where leads are kind of placed here. You can see in the upper right corner, they'll place these leads through this S1 foramen, and it'll stimulate the S1 DRGs, which can usually give us good coverage for painful peripheral neuropathies. And get those feet, which is what the DRG stimulation is really good at, is getting foot pain, distal pain far away. It's not approved above the T10 level, so generally not used for upper extremity pain, but it has been explored. And then the last kind of thing that we'll talk a little bit about is, so if the, and I do see a lot of migraine headaches, so this is where it's something that I kind of am observant. In patients, which is a very large percentage of the population, potentially up to 20% have migraine. Well, if someone with migraine also suffering from painful neuropathic pain, there are these CGRP monoclonal antibodies that you might get a side benefit of improvement in their neuropathic pain. And there are 4 commercially available. The galcanezumab, erenumab, and fremanezumab are sub-Q injections that are given by the patient. And then there's another IV infusion called eptinezumab that are given infusions in an infusion center. In this study where it looked at neuropathic pain, about 41% improvement in neuropathic pain after 12 months of treatment, which is pretty exciting in people that had very bad to treat pain. And then they also had improvement in their headaches too. So it's kind of a win-win situation. So it's one of those things where these medications may be a good option in someone who has tough to treat migraine headaches, and you may get that side bonus benefit of some neuropathic pain improvement. Things to note about is I would avoid it in secondary Raynaud's phenomenon. So scleroderma, those types of disorders. If Raynaud's phenomenon is present, this is not a good medication. And you have to try 2 oral preventive medications, and things like gabapentin and nortriptyline count. So something to think about. So in summary, I think I have the best success when I look at the characteristics of pain and comorbidities to determine which medications to try. Topicals can be a nice treatment adjuvant, but it's not the sole treatment option. Scrambler therapy is a promising therapy, but it can be hard to get coverage, but it is well liked, and a non-invasive treatment that is a decent option. And if patients do have migraine and they have a pretty bad neuropathic pain, they may be responders to this CGRP monoclonal antibodies, but keeping in mind that the indication is migraine and not the neuropathic pain. The neuropathic pain improvements is just kind of icing on the cake. And in patients who've tried 2 oral, neuromodulation medications, and they're still having pretty difficult to treat pain, then it may be reasonable to move forward with something like an implantable device, like a spinal cord stimulator or a DRG stimulator. We didn't discuss it, but peripheral nerve stimulation is even another topic if they have a real focal area due to one single nerve distribution of pain. But I hope you get out of this that there's a lot of treatment options available, and it takes a little bit of trial error, but hopefully, pain can get well controlled with these options. So thank you.
Thank you, Dr. Mauermann and Dr. Kissoon, for both of your very informative presentations. With the time remaining, and luckily we do have some time, which is great, we will now move into the Q&A portion of our session. We have many questions from the audience that I have been lining up here in a document. So as a reminder, if you are going to ask a question, please ask a general question. So I am going to look here on my list, and Dr. Mauermann, if it's okay, I'll start with you, because you did have a slide mentioning cryoglobulinemia, and that was something that someone had written in about. If you could speak any more about cryoglobulinemia having to do with nerve issues when like with the Waldenström's patient only presenting with neuropathy and cryoglobulinemia.
Sure. So cryoglobulins are one of those complications that can occur in a smaller proportion of patients with Waldenström's, and can occur even without Waldenström's. And those without Waldenström's, sometimes we see a different type of cryoglobulinemia. So in Waldenström's, it's usually the type 1 cryoglobulins, or the IgM. And in those that are associated sometimes with the hepatitis virus, is usually type 2 and type 3 cryoglobulins, and that's kind of the IgG, or a mixed pattern of that. And cryoglobulins often have skin manifestations, kidney involvement. Their problems are related to the fact that the cryoglobulins lead to deposition of immune complexes and complement activation, cascade in the nerve. And so they can present with a usually asymmetric peripheral neuropathy, or they can involve individual nerves. You could get just like a foot drop, or just get like a wrist drop. Or it can be asymmetric, like one side worse in terms of sensory and motor. And by that, I mean, everybody has a little bit different side to side, but we're looking for typically like around 50% difference in terms of the severity of the weakness, or a really significant difference in how far the sensory deficits go. And the neuropathy, typically when we do an EMG, looks very axonal, meaning it's really damaging the underlying nerve fiber itself. Cryoglobulins can have a certain different treatment aspects to them, in terms of, might we institute rituximab or plasma exchange or other things earlier, and so that can play a role in terms of determining treatment.
Thank you very much, Dr. Mauermann, for that helpful answer. I'm not sure who this would go to. Maybe Dr. Kissoon, because you were mentioning some of the different types of therapy. This question's about hyperbaric oxygen therapy, or HOT, for peripheral neuropathy. Is this therapy done effectively with injections locally, like in the feet, or does it imperatively imply use of chambers? I don't know who might be able to answer that, but Dr. Kissoon, looks like you're going to jump in. So.
Yeah, I don't know if I have a great answer to that. I'm not 100% familiar with it, but I'm guessing based on the description that it is a hyperbaric chamber, and that, you know, it's something where you do hyperbaric treatments. Any thoughts, Dr. Mauermann?
Yeah, I agree. That's probably what it's being referred to. I haven't had any particular experience with that or success, I would think.
Well, thank you both for your comments. Dr. Mauermann, this one goes to you from the patient. How do you decide in a WM patient with Bing-Neal syndrome whether the neuropathy is due to WM or Bing-Neal? Is the treatment different?
Well, Bing-Neal in general, I would consider more of a central nervous system complication of Waldenström's. And so I would usually think of the peripheral neuropathy as also a complication, but separate. And in terms of Bing-Neal, usually what we're seeing with that is that it is infiltration with malignant lymphoplasmacytic cells. And so it's usually, most commonly, it's occurring years after the diagnosis of Waldenström's, and patients can present with a variety of features. And that's because the main problems, either that there's like a mass-like lesion in the brain of lymphoplasmacytic cells, or there's leptomeningeal, meaning it's involving the coating around the brain and spinal cord. So you can get involvement of nerves and muscles, usually kind of diffusely along the spinal cord. So that would be a case where it's more of a polyradiculopathy involving versus involvement to the peripheral nerve. So how would we tell that? We would tell that by the exam, looking length dependent versus more proximal and distal. We'd be looking to see if reflexes are all gone all the way, you know, throughout arms and legs, because that would suggest a more diffuse process involving those roots. And the EMG would help us too. So they're really kind of different localizations in the nervous system.
Awesome. Thank you very much. Dr. Kissoon, this is for you. Regarding gabapentin, why do you start with a dose of 300 milligrams rather than 100 or 100 twice a day?
That's a good question. You know, every patient and every person is different on the medications. It's kind of that middle ground dose where we can get up to a higher dose in a quicker manner. But you know, at the end of the day, if lower doses are effective, it works. The one thing to be very careful about with gabapentin is it is cleared by the kidneys, and so that has a major impact on where you start out with the dose. So if someone has a kidney problem and they're which can be seen in things like Waldenström's macroglobulinemia, you know, then you'd have to be careful about, you know, not starting at too high of a dose and have a lower dose to begin with. And that's where something like 100 milligrams per day would probably be a better approach, or much slower titration. And usually with kidney issues, you don't go higher much than like somewhere around the 700 milligrams twice a day, or even lower, depending on how the kidneys are doing. So, so very important to not do too much medication, and the dosing that I mentioned was more in when kidneys are working a-okay, but never to go low, but a higher dose. We usually like to get people with normal kidney function up to a 600 milligrams 3 times a day dose.
Thank you very much, Dr. Kissoon. And perhaps on the topic of medication, since you had listed several in your slides, do you use Cymbalta instead of, and I might pronounce this incorrectly, amitriptyline?
Yes, we do. and I sometimes use both. You know, the duloxetine is a pretty common medication, so I didn't go too much into the depth with that. And there are studies that show that it's quite helpful, and most notably in like chemotherapy-induced peripheral neuropathy. The dosing with that medication, it's like a 20 milligram tablet, and then it's, you know, increased over like 3 weeks to 60 milligrams. And usually we find that the 60 milligrams with the duloxetine is, you know, higher doses than that aren't that much better for treatment of nerve-related pain. Sometimes I'll have some people on the duloxetine and something like the nortriptyline or amitriptyline, but you have to be very careful about how high you go up on both of the medications. And I wouldn't, you know, with like things like the nortriptyline, I wouldn't go up higher than 50 milligrams. So it's a tough balance when you're on a lot of medications, and the duloxetine can be a great medication that's well tolerated, and one I often use too.
Thank you very much.
And I would just add to that too. I mean, sometimes instead of duloxetine, venlafaxine is an alternative to that one too. They work similar mechanisms. So that could be another one that's considered in there as well.
Yep.
And good for people with coexisting depression, which kind of can come along sometimes with neuropathic pain when you feel like you're just not getting relief, you know, your mood. I mean, it can be more than just a subtle mood. Sometimes we need to treat both conditions, and that can be a helpful medication.
Yeah, that's an excellent point.
Thank you. Someone said, you know, maybe this is too specific, but wondering if a person only has peripheral neuropathy in their hands, not their feet, does that indicate what type of peripheral neuropathy it is?
Yeah, that's a great question. So typically we think of peripheral neuropathies again being more length dependent. So if we just have symptoms in the hands, we would probably think about, is there a more common thing like carpal tunnel syndrome going on that can mimic peripheral neuropathy? We might think about the cervical spine as being a potential localization of where those symptoms could be coming from. Someone have degenerative disease in their neck, and that could be causing the symptoms. But some neuropathies do involve the hands more, especially we see that with some of the chemotherapy toxicities, that they're not typically just like a length dependent neuropathy, and they can involve hands and feet at the same time, or preferentially hands. So that might be something to think about, but it wouldn't be the most typical pattern. And so we would think about, do we have the right localization first, and then thinking about the causes.
Thank you. And I'm not sure if you all, with your research, is there any research being done on the mechanism that causes monoclonal IgM to attack the myelin?
Yeah, I mean, there is a lot of research looking at why does IgM, we know that IgM, where it's antigen binding site is to that myelin associated glycoprotein on the nerve, on the myelin sheath, and that we see that the IgM deposition causes widening of the lamellae of the myelin. So you thought about those donut picture I showed on the biopsy and those little donuts. That myelin is more than one layer, and so it gets kind of it's usually very compact, and it gets spaced out when we look pathologically with the IgM. So we know there's some reason there. We think that with the IgM, there's a problem with the monoclonal protein and probably the immune cascade for which it triggers based on that. And we know there's association with these MAG antibodies, but they don't necessarily correlate well with amount and severity, or titer and severity at this point. So they're involved, but exactly, you know, all of the underpinnings of that yet aren't fully worked out, but we do know some of those details at this point.
Thank you very much.
Mm-hmm.
Dr. Kissoon, scrambler therapy has been a hot topic that a lot of our folks were wanting to learn more about. So thank you for including that in your slides. Someone asks regarding scrambler therapy, might it be effective for chemotherapy-induced peripheral neuropathy that is long-standing, and does it affect numbness?
You know, that's a good question, and I don't know if I don't think the prior studies looked at how long the symptoms were going on and how long it was, if it was better, if it was a more recent peripheral neuropathy, or if it's been going on for 10 years. So I don't know if I can comment on it, but I think if it's covered by insurance or something within your means, it's not, there's low risk involved in that, and definitely worth something to try at some point, especially in the chemotherapy-induced peripheral neuropathy, which is what the data is best for.
Thank you very much. And I know we are coming up on our time, so if you have time to maybe take one more, and I want to thank everyone for your questions, and I'm sorry we didn't get to all of them. But let's see if we can squeeze in one more if you all have just another moment. What next steps could be considered with small fiber sensory neuropathy that does not improve or even gets worse after a first-line treatment for WM?
I guess one for small fiber, in terms of before the symptom management, I would just reassure that in terms of small fiber neuropathy and latest data about that we only find the cause of small fiber neuropathies in about half of patients, but we do know long-term prognosis is that it often stays confined to the small nerve fibers and doesn't progress outside of them. And so while it's a painful nuisance neuropathy, often patients don't go on to develop a lot of numbness or weakness. So I think that's one good part about small fiber neuropathy. The bad part is obviously treating the neuropathic symptoms. To me, I would say if the first line is failed or it's only modestly effective, I would still try to think about combining those with topicals, just because a lot of small fiber patients have a lot of contact sensitivity, burning, and those can respond well to the agents that Dr. Kissoon mentioned in the creams. So sometimes a combination with an oral can be helpful. And then I'll let Dr. Kissoon comment, but I think, yes, there's still a lot of hope if one agent doesn't work, that something else will provide benefit. No one's saying that pain will completely be gone. I think a lot of the studies are looking at a 50% reduction in symptoms as being, quote, efficacious. And so I think, though, for a 50% reduction is pretty meaningful for a lot of patients in terms of their pain.
And in regards to the pain management, unfortunately, we're not that great at picking the right medication first. We do the best with what we know, with what's worked in the past, but sometimes it's trial and error. And the nice thing about it is that we have all these other options, even if we do try a couple of medications. And sometimes it's multiple medications. Sometimes it's a medication and a device. Sometimes it's medication, topical, and device. And I think more often than not, we call it multimodal therapy, or therapy and treatments in multiple different ways to get the person in the right spot.
That's great. Thank you very much for your helpful answer. And I do want to, thank both of you, Dr. Mauermann and Dr. Kissoon, for taking the time to meet with us today and sharing your wisdom with us. I'm really blown away by what we've accomplished in an hour. And again, I know some of you are disappointed we didn't get to your questions. There were so many coming in, but we tried to do as many as we could in this hour. Thank you to the docs for your compassionate hearts with the work that you do to help your patients obtain a better quality of life living with neuropathy. It really means a lot. We were really looking forward to having you. So thank you both.
Thank you. A pleasure to be with you all today.
Yep,
Hope you guys enjoy your rest of your day.
Thank you.
And I love the cute puppy that was in one of someone's lap. That was cute.